Hello again everybody. So in our lecture series so far, I've taken you through the biology of neutrophil extracellular traps and some of the science behind our test proving our test works. But what Volition has to do is show the clinical relevance of H3.1, and what I'm going to take you through now is through some of our early studies and then highlight where our research is going in the clinical arena. And we're very excited by this and the work we're doing in this area. This is the first paper. It comes from COVID. And when COVID kicked off, there was such stress on the healthcare systems that we tended to define patient severity of illness by geography, where they were. Were they in an outpatient and sent home? Were they admitted to hospital ward? Or were they admitted to intensive care? And what you can see in this small series of patients is that those patients admitted to intensive care and those who died had a higher H3.1 level. In some ways you could argue this is like a dose response curve. The sickest patients had the highest level of H3.1 and their activation. And you can see clear separation in the graph as you go up. This is just an early window, but an early signal saying something important around the H3.1 signal. This signal was repeated by my colleague Catherine Ray, and this abstract was published at the International Society of Thrombosis and Hemostasis meeting in 2021. This is looking at ITU patients now. It used the WHO scoring system for COVID, which was valid at that time, into severe and non-severe COVID. Severe, you had to be ventilated. And again, you can see much higher levels of H3.1 in those patients who were ventilated. And you can see a difference in the medians here, and that was statistically significant. And again, it was just higher than those patients with non-severe COVID. But again, these are sick patients. The graph on the right of this slide is important because it's starting to show the potential value of H3.1 in monitoring patients. So the graph on the left is picking up severity, perhaps helping with diagnosis, but identifying severity of illness. It definitely looks like there's a severity signal. The higher the level, the more poorly the patient. The graph on the right is suggesting if you used H3.1 in monitoring, that the different trajectories in H3.1 are clinically useful. Those patients who died had higher H3.1 levels overall, so a worse severity signal, but it remained high. It didn't fall over the duration of their ITU admission. Whereas the patients who survived did have a lower H3.1 level, but it fell. It fell and improved during the course of their admission. Again, suggesting that there's something different in the immune responses of these patients. Again, it's small numbers of patients, but it's starting to really point to a biologically relevant signal that we need to understand and explain in more detail. This paper was published by Morimon in Biomolecules in 2022. In intensive care, we use the Sequential Organ Failure Assessment Score, the SOFA score, of basically a way of adding up people's organ failure. It enables us to compare one paper with another paper to make sure we've got people of the appropriate sickness in them, basically. It just makes sure a much fairer comparison. And this is really interesting to us because as people's SOFA scores increased, as their severity of illness, as their degree of organ failure increased, their levels of H3.1 increased again. This is in a mixed population. Some of these patients had COVID, but many of them had sepsis. And you can start to see now a pivot away from COVID to sepsis. But again, you're starting to see this biologically relevant signal. The sicker a patient is, the higher their H3.1 levels. This fourth clinical study was done with our colleagues in France, Guillaume Monneret's laboratory. And again, you're seeing a signal between severity of illness with H3.1 concentration being higher in survivors and non-survivors. The graph on the right-hand side of this slide shows different trajectories of patients. Patients with a higher SOFA score had a higher H3.1 level and a worse clinical prognosis. And you can see separation here in the green line and the orange line. Again, suggesting that H3.1, monitoring and tracking H3.1 levels, provides very useful prognostic information on a patient's severity of illness. These initial 4 studies have been incredibly useful for us to learn, to understand and try and articulate more questions going forward. These questions have enabled us to design the future studies better and to chase ever more clinically relevant questions. Really, we're trying to obtain a deeper understanding of the biology of sepsis to enable us to move towards better diagnosis, diagnostic enrichment, prognostic enrichment, and personalised medicine. What studies have we got going forward? Lots. In America, we're working with our colleagues with the CLUDE study, and that's looking at around about 180, maybe up to 200 patients presenting to the emergency room with sepsis, trying to identify or see if we can distinguish the severity of sepsis patients are suffering. So we aim to have all that data collected by the end of the summer, and we'll look to publishing it probably early in the new year. We're working with our friends and colleagues in Paris, Professor Djali Anand, on the RSU records study, and we're looking at about 450 patients at the moment in that. Again, trying to describe H3.1 levels and the kinetics or the trajectory of H3.1 in patients admitted to their intensive care. We're really excited because we're working with our colleagues in Jena in Germany, and we've just received data on just under 900 patients, and again we're doing the same thing there. There's an incredibly rich data set for us to look at of patients admitted to ITU with severe sepsis and septic shock. Again, we're looking at H3.1 levels on admission. Can we see a severity signal? Can we see a mortality signal? And then we're looking to see the trajectory of their H3.1 levels over the course of their admission. And we hope to have that data processed by the end of the summer. And we very much will be hoping to present that data at the European Society of Intensive Care Medicine meeting in October this year. The largest study we're working on at the moment is with just under 2,000 patients with our colleagues at UMC Amsterdam. And again, it's a very common theme coming up here, is we're looking at H3.1 levels to try and check severity of illness. Can we start to identify a subtype of sepsis, a group of sepsis where NETs tell us something extra in which we can adjust and adapt our therapy? And again, we aim to have those results processed and analysed by the end of the summer. And again, we'll try and very much aiming to present preliminary findings at the European Society of Intensive Care Medicine meeting in October this year. But that's a really comprehensive panel. We'd be approaching at the end of it 3,500 to 4,000 patients where we have studied H3.1, its diagnostic ability, its prognostic ability, and its monitoring ability in a very large population of patients. And we're very excited to keep working through that data and analysing that data. And as soon as we have more data to share, we will obviously be sharing it. Thank you.